Yes. Hi, doctor. Good morning.
Good
Uh,
morning.
this is, I think, is it the last Saturday of this April month? Yeah,
Yeah,
it is. And then we are
yeah,
so glad to have Dr. Vikas Agarwal
yes.
with us. In fact, we had him even on the first Saturday or first Sunday of this month with us when we had Narasimhan Memorial Lecture. That's how we kicked off the month, Parkinson's Awareness Month. And then Doctor was very gracious. He joined us in person that time to, interact with our members one-on-one. When we had the talk where Dr. Arul Selvan was talking. And now he's agreed to do an online session for us to clarify some questions on how to manage Parkinson's disorder. Doctor, I will let you give your qualification introduction, but let me give an introduction about how you have been helping us in the community. So we have now known Dr. Vikas Agarwal for more than 4 to 5 years now. Lot of our members have had their DBS surgery done by doctor, and he has been associated. We have known him since he was associated with the Global Hospital, which is now called Gleneagles in Chennai. And now currently he's with Kauvery Hospital and SIIMS. I can say very confidently that one of the few doctors in Chennai who is an expert in doing DBS, very kind with his patients and spends a lot of time. And any feedback we have received from our members has been excellent. They say doctor spends a lot of time in programming, talking to them, counseling. So, and more than that, even for me and Dana, when we have any questions of any other members, all we have to do is to WhatsApp doctor and he'll definitely give his best possible answer. He'll not say like one thumbs up or yes, good, it'll be impactful. He'll not give those cryptic answers which we have to decode, but he'll in fact, write down a proper answer saying, yeah, this medicine will cause this side effect. It can be taken, not be taken. So we're very grateful to have a resource like that literally at our fingertips. We could always reach out to him. So it's just very appropriate that we do this session with Dr. Vikas today. So thank you, doctor, once again for coming. And why don't you tell us a little bit about your qualification and your experience as a neurologist before we begin with questions?
So, welcome to everybody who is on live today with us. I'm a simple clinical neurologist. So, I got trained under Dr. C. Velmugendran sir in Chennai, and I worked with him for some period of time in Ramchandra Medical College. After that, my interest was little bit in epilepsy. So, I went to Sri Chitta Institute in Trivandrum and got trained in epilepsy there. This was way back in 2012. And then after that, I was working in Apollo for a long time, 8, 9 years. Apollo Chennai main hospital and in Tynambet. And I was primarily doing into epilepsy. But then something happened. No, I was seeing a lot of PD patient, and uh, I also have my close family member uh, as a Parkinson patient. And then I thought, why should, as a neurologist, why should not I go into and learn more about it and how to take care of these patients in a 360-degree manner. So that is very important. See, we talk about 360-degree care for any disease or any illness, but it is very important that we actually practice it. And that doesn't mean only surgery. It means a hell lot of medical, non-medical questions, which may be very trivial, but for an individual patient, it may be very, very important. So that is something which I have learned. So I went to Malaysia and I did a fellowship in movement disorders and deep brain stimulation and Parkinson's disease. That was in 2019. And then I came back and I started working with my guru in epilepsy, Dr. Dinesh Nayak sir. And we worked together and we launched the program in global of a very active program where we did almost 10 to 12 surgeries over a period of 2 years. And then subsequently, I have been into several hospitals together. But lately, because last 2 years, my father illness has progressed. So I have to come back home here in Assam. And now I work on a hybrid model. I do visit Chennai every month or 1.5 months for 10 days, and I see my patients there. And we are actively doing DBS. And I have a team of colleagues, neurologists, who help me in case of any emergency or any kind of emergency required. And I'm always available in WhatsApp to answer my patients. So this is how the journey has begun, and I feel we are doing too little for a too big of a problem and too immense of a problem. Why I say this is that when we were in Malaysia, we actually published a paper in Lancet. And this paper, I was not the active PI in that, but my professor was. And what we found that in the Western Pacific Asian region, Western Asian region, and this Pacific region, the incidence of Parkinson's disease has been, quite high. And now we are getting, you may Google anytime and get various data anytime. But the fact of the matter remains is that definitely we are having more and more cases of Parkinson's disease. Uh, I believe one reason for that is more awareness. So we are more aware about the illness now, and we know that patients are and family members are getting aware. Earlier, it was thought that it is an senior citizen problem, and it is because of the old age or whatever you say, senior citizenship. But now family members are aware that no, there is some problem and medical help is required. And that is where we stand today. And I really thank Parivarthan Group and Madam Sudha Mayappan, Madam Dhanalakshmi. You've been doing very phenomenal work. I think you are the only NGO now in Tamil Nadu and across the country who is really into Parkinson's disease, except for all other NGOs which comes up and
Yeah, that's very kind of you to say. But there is another group in Bombay.
yes, Bombay also they are doing better. I'm
Yeah, they
glad.
are doing a very good job in
In
Bombay.
Chennai, you are the only active group.
Yeah, at least in the south of India, we are the only ones. There's also a smaller group in Calcutta, doctor. And there is one more in Ahmedabad. Dr.
Ahmedabad.
Bonita Singh is running in Ahmedabad, and in Calcutta, Mitra, Madam Mitra is running it. But
Okay.
yeah, so there are smaller groups for sure.
But
Uh,
is Parivarthan the oldest among them?
no, I think the group in Bombay is the oldest.
Bombay is the
PDPMS, they are the
PDPM.
oldest, and they're also the biggest. They represent India in Parkinson's across the forums. They are doing a very good job.
I think South India, we are one of the,
We are
you
the
are,
only ones. We are the only ones, actually, honestly. And more so because we also have a proper staff. We now have a supportive care center where we
okay.
give all the therapies for free, like physio, yoga, occupation therapy, speech, everything for free for
Oh,
people with
very good.
Parkinson's.
Where is this center located? Can you?
Yeah, it is in Arumbakam, doctor, near Anna Arch in Chennai. Uh,
Mhm.
yeah, so we launched it only this year. We've been having programs online and offline, weekly basis. Now we have started daily basis. So
Yeah.
now we have a proper staff setup. So at this level, maybe NGOs are not functioning, where everything is offered for free. Anybody can come in, get food, and get all therapies for free, things like that. So that is definitely the first that I know of, at least in Chennai.
Good.
Uh, and we are going to open it up to other neurological disorders also, like
Oh,
stroke, or if you have multiple sclerosis, you could still come. Like doctors, like you can come once for a consultation and then they'll have physiotherapy. So we've tied up with a couple of physiotherapy units, Yoga Vahini, there's a yoga school.
okay.
SRM is doing the speech therapy for us. Pain and Stroke Rehab Center in Chennai, they are providing us physiotherapy. So we've collaborated with institutions who are good at their work. So all we have to do is to coordinate and make sure members come. So yeah, so I'm happy that we have progressed to this level. Now, doctor, you have vast experience. So I want to just break down maybe a few things and start off with some myths about Parkinson's or some common misconceptions about Parkinson's. If somebody comes to you as a patient, I'm sure a lot of your patients must have asked you, why me? What could I have done to prevent this? When they're first diagnosed, I think the guilt, I mean, if it is cancer, if it is like lung cancer, then maybe smoking. There are some related causes like that. I'm sure a lot of members ask us, and I'm sure a lot of patients ask you, what would be your answer for something like this?
So there are two questions here. One question is why me, and another question is can it be prevented? So I was actually hoping that this will be, I was thinking that this will be your first question. And I actually downloaded, I will share it with you later on, a very good article, and this article has come in neurology. And it says, this was in very recent actually, 2022. And it says, planning for prevention of Parkinson's disease. Okay. So we are not in that stage where we are able to prevent Parkinson's disease therapeutically. But of course, we will talk about non-therapeutic measures of Parkinson prevention, which is diet and exercise. But therapeutically, at present, we are not in stage. And I mean, many of your members, I will share this with you. You should share in your group. And this is a very good, realistic article which says that we are slowly, but we are making some progress in preventing Parkinson's. So the progress has come the way I will, let me explain. Take 2 minutes of your time. So usually what happens, we know that only 10 to 15% of Parkinson's is genetic Parkinson's disease. Okay. Now, when we want to prevent any disease, we need to recognize the disease before the disease starts actually showing the symptoms. What we call it as a predromal or prodromal phase. And that is where the problem is. Because in Parkinson's disease, you have a hell lot of prodromal phase symptoms or non-motor symptoms, which may be there for many, many years. But it doesn't mean that if somebody has that prodromal phase symptoms, they will transform always into a Parkinson's disease. So the word which is used technically for this is called as phenoconversion. Phenoconversion.
Eno or pheno, doctor?
Phenotype.
No. PH.
PHENO,
Yeah.
phenoconversion. So this is a new concept which
Uh-huh.
is coming
Never
now,
heard. Okay.
which is I think many of your members will be interested into.
Yes,
What
yes.
they are looking into is that now you see 10 years back or even 7, 8 years back, doing a genetic test was very difficult and expensive also. Still also it is expensive in general terms. But when we do a genetic test and we found that the patient is having a particular genotype, okay, so I think you really need a cetirizine today.
I need like I'm so sorry, doctor. I'm so distracted with
So
my
please,
nose,
please have
running nose and my
something,
sniffles. So
flu.
apologetic when you're talking about something so important.
Nothing,
Please go
nothing,
on.
doesn't matter.
Ignore
But
me.
at least go, let me.
Look at Dana. Don't look at me.
So, so the
Dana is calm. Yeah,
point
go.
is that, this phenoconversion can happen at any time. But one thing what we are realizing that even if you, by me, when you ask no, like see, now if my family member has a Parkinson disease, and there are two or three important genes like LARC2 or GABA, these are the two genes which are very important, which now a lot of research is happening in these two subset of patients. But even if the another family member is having this particular gene, it doesn't mean that they will phenoconvert to Parkinson's disease. So that is one very important point we know. And even if they phenoconvert, that means your sibling or your members, other members, if they are becoming Parkinson, the phenoconversion doesn't happen in 1 or 2 days or 3 days or 1 or 2 years. It takes 20 to 30 years. Okay. So my take home message is, first of all, when you have a gene test getting positive, family members, what I've seen is there is a panic in the family members. So patient's family members, oh, whether my son, and in spite of the patient also, because whether my son will get it, my daughter will get it, what will happen to my siblings, those lot of questions come in, which is very, very obvious. I would say that we are way behind to tell it very confirm or to give some kind of a very confirm answer that no, your sibling is going to become PD. So we should not panic whenever there is a positive Parkinson gene result. Now there is
Sorry, can you say that again? What are the two things that you said?
the two
Genes.
genes which are very common in which research is going is one is LRRK2 LARC2 gene,
Okay.
LRRK2 gene, and GBA mutation. These are the two mutations in which there are many other like PINK and DJ1 and so many gene mutations are there. But what the researchers have found that these two genes, they are usually presenting at a late age, say
Mm-hmm.
after 50 or 60, the typical Parkinson's age.
Mm-hmm.
They are not very young onset Parkinson's patient. And what they are trying to do in this group of patients is they are trying to do some pick up a cohort of cases and see patients who have other family member gene positivity, and then any kind of preventive trials or strategies can be employed pharmacology but pharmacologically, but we are still way ahead, I mean behind that goal. uh, and why me? Because many things happens because God wants us that way, maybe. So we should not feel why me, any cancer patient thinks also like that, why I should get the cancer. So I think it has a lot to do with your genes also. And then the genes are getting modified with the environment. So we know, we talk always about pollution. Now we know that air pollution and other sorts of pollution are associated with stroke, which is another common neurological problem. So there are urban studies which have showed us association between air pollution and stroke, or air pollution
I
and
didn't know. I wasn't aware of this. Air
yes,
pollution and
yes,
stroke.
yes, yes. So urban centers where they are. So these are kind of association things which we find. Okay, this may be a risk factor, or pesticide use. So in
Oh,
US,
that definitely, doctor.
it is a Pandora's box now. You know the famous story in US when the PD and the from the pesticide use and the litigation which happened for many many years. So many PD patients they have then developed PD after this organophosphorus and other kind of
Is this a
pesticide.
study that you're referring to? I'm not aware
No,
of
no.
this.
I'm talking about. See, there was this litigation which happened in the
Litigation.
company, yeah, in US, because the farmers said that the
Oh,
uh,
pesticides,
yeah,
big
pesticides.
time, huge study. There was a
Yes,
huge proven case that then a particular kind of pesticide was
correct.
increasing the incidence of. In fact, we have had members who are farmers who have had developed PD.
Exactly. So those kind of pesticides usages, it was a German company, and then those usages have come down now. That's
Yes,
why now people are more and more moving towards organic farming. So,
yes, yes.
so I'm not saying that they are bad for everything, but there are association with these kind of environmental factors.
Environmental factors. So, doctor, just breaking down whatever you're saying gradually. So, you're saying there are genetic factors, there are environmental factors. In genetic, if there is a family history of PD, only 10% you're saying approximately, there is a conversion that another family member is likely to have. That's one. And then even if you have they usually call this in PD the gun and the trigger, loaded gun with a pull factor. It's already a loaded gun if you have a genetic predisposition, but the trigger could be external environment, which is what you're saying. And not everybody, which is a loaded gun, just fires also.
Yeah, that's
Uh,
not every gun fires. That's
Not
the
every gun fires. Yeah. So this is one common example they give in PD. Also, doctor, just going little bit more back to what you were saying, this phenoconversion that you said. Is this phenoconversion only from genetic to actually being affected with PD, or is it generally even idiopathic PD, even without genetic factors? The damage is happening inside, but by the time the manifestation comes out, is that phenoconversion?
yes, that's a very good and very important question. See, there are two aspects of this. One is the genetic aspect. Now, now we know that many members of, and we see practically also that patients who are Parkinson, but their family members, many of them has essential tremors. Okay, or so it need not an essential tremors. Okay, genetic, non-genetic forms, but they may not have a gene which is positive, but they have a phenotype, a different phenotype. Like they have essential tremors, which is not Parkinson, and it is said that patients of essential tremor usually they are a stable condition, and it doesn't progress over many years. But then there are studies which have shown that even after 8 years or 10 years, some of the ET patients can convert into a benign tremulous Parkinson.
Oh, they do?
Yes, yes. So earlier, what we used to call that BTP, benign tremulous Parkinson. So my boss will always check rigidity for any essential tremor patient because it may be a tremulous Parkinson. So, so now those concepts are little bit changing as the more and more movement disorder societies guidelines are coming. But fact remains that phenoconversion is a very important factor and an important thing which happens in movement disorder across different subsets. See, somebody can start with a chorea or a dystonia or another kind of a movement, and then develop into something else later on. And this is the reason I will like to bring at this point is why the DBS criteria has laid down. So a patient comes to your clinic and you should wait for at least 4 or 5 years to see if it is phenoconverting into PD plus, because
Oh,
there the DBS will not work.
So you have to wait. You can't like be diagnosed with PD and quickly jump into DBS
Jump
because you
into
want to see the progress of the disorder.
progress of the disease. Suppose if you are not sure about the history, you know, many
Mm.
times you are not sure. Patients may be having Parkinson's for say 3 years, 5 years. In one of
Right.
the studies, the average duration of diagnosis by even a neurologist was 17 months.
Yes, yes, easily done.
So 1.5 years is the
Average, correct.
average for a
Exactly,
PD.
exactly. So
Because
true.
many times they will be going to first physiotherapists, then orthopedic,
Ortho.
then spine surgeons for
Yes,
spine. Some of them get operated for spine
correct,
surgeries. Then only the or orthopedic surgeries or knee joint surgeries. Then only they land up for Parkinson.
correct. Totally agreed. I mean, in the
So,
amount of members we have spoken to, this you're exactly right. 1 to 1.5 years is the average by the time they figure out.
so my practice in my practical approach, what I usually do, even if I know this patient is a very good candidate for DBS, I tell them you wait for some time. I want to see them for say at least 3, 4 times. You
Okay.
know,
Oh.
then yeah, at least 2 to 3 times or 4 times, and then when I am sure that I am dealing with something which is very consistent,
Mhm.
and this can only be done by clinical examination. There is no test or MRI
Uh,
for this.
thank you, doctor, for
There is
saying
no
that.
test for
Say
this.
that again.
There is no test for anything beyond better than clinical test. Okay, because in Parkinson, the management depends only on UPDRS, only on your motor scores, your non-motor findings, your symptoms, and there is no test which can quantify it.
Correct. Quantify, diagnose. It's all clinical. Yeah.
So it has to be clinical, and you and the physician and your general neurologist, whom you are going regularly, is in a very good position to know, Are you have deteriorated or you have become better. To say
Correct.
this, you
Correct.
know, it may be very difficult for a new person to see. I may be a PD expert, but if my colleague is seeing a patient for 10 years, he knows better about that patient than me. There is no shame in saying that.
That is absolutely true. Very well said. Um, Doctor, one leading question based on what you just said. A lot of doctors, I'm sure it's very recommended, TRODAT scan for PD is recommended.
Uh,
To expand a little bit on that.
well,
Because we're talking on diagnosis, I thought I'll bring that up.
I see a lot of patients who come to me because I'm an expert and I get referral cases already told and done to them, and it's written could be PD, essential PD, or TRODAT, or whatever, even DOPA scans and all. Uh, I am not against any kind of scans, but I have no comments to for the doctors who are doing this. It is a thought process which they believe, and I have a lot of respect to that thought process. But in my clinical practice, I'm individualizing this answer. In my clinical practice, I don't do TRODAT.
Oh, okay, I didn't know that. Oh, that's interesting.
I do not do TRODAT to diagnose Parkinson's. I do PET scan sometimes.
Mm.
Okay, and the reason for that is when suppose I am seeing a patient whom I am suspecting a Parkinson plus syndrome, I want to rule out in general, am I am dealing with any kind of a malignancy or a hidden disease
Oh,
which is mimicking as a Parkinson's disease.
it happens that mimicking happens.
Happens. Yeah, it happens. There are PSP atypical variants, where they have found, CA cancer, pancreas, I mean thyroid, or any other thing mimicking as a Parkinson. Patient may become slow, they may have some non-specific tremor because of the age, and then the picture may look like a Parkinson's disease. So
Mm.
in that case, second thing, sometimes to look about in terms of Parkinson disease dementia, I will do some PET scan. But
Mhm.
the better PET scan is a amyloid PET. If once it comes, more availability comes,
Is it
that
done
will.
in India, doctor? Amyloid PET?
I don't think it is there actively now,
Yeah.
except
Mm.
for I think AIMS was doing some research on that initially,
Yeah.
and but once it comes more in practice, then it may be of some use to our patients.
Mm.
But
And
more than that, because you are asking about diagnostics, we should we should bring our attention to something which is going to change the face of PD diagnosis.
yeah.
Okay, and that is what it is a skin biopsy test.
Oh, is it?
Yes.
Mhm.
So there was this huge trial which has come extremely successful from a Harvard-based, Beth Israel Center,
Mhm.
and they have done what they have done basically is that patients who have PD phenotypes
Mm.
or who are Parkinson's or who have prodromal non-motor symptoms of Parkinson's, they have done simple biopsy of the skin. Like
Okay.
it's like dermatologists keep doing that day in and day night.
Mm.
It's just an OPD thing. So they do a chin, here neck one biopsy, one from the thigh, and two, three sites like that, and look for. We know that Lewy body and alpha synuclein is the pathological problem in PD, the protein. And what interestingly, see, this knowledge was there for many years. Okay, what is interesting is 90% of these patients who have PD, the biopsy was positive.
Mm.
Okay, so and these are the patients. There are all the synucleinopathy group. So there is among the synucleinopathy group, it is not only Parkinson, but it is also other diseases. Also, there are three other diseases. If I may speak,
Yeah, yeah.
one is multisystem atrophy, which we know is a PD plus condition.
Mm.
Okay, another is primary autonomic failure.
Mm.
Primary autonomic failure. All these conditions, and these conditions are synucleinopathy and diffuse Lewy body disease (DLB). So these four conditions: Parkinson's disease, diffuse
Mm.
Lewy body disease,
Mm.
primary autonomic failure, and multisystem atrophy. These are actually alpha synuclein related or synucleinopathies, what we call it as.
Mm.
And
Mm.
when we are dealing with synucleinopathy, this biopsy test will become a very important entity.
I
So
see.
now, how it will help in future, and it may help in future. I am not advocating the test. I am not. Again, I have no association with any company to advocate any kind of a test. I am just saying what has come into research, and it may come as an MDS guidelines also in future. What is important is that, see, now you have some prodromal symptom, like you have a non-motor symptom, you have a sleep disorder, or you have constipation. You can get a biopsy done and see whether you are synuclein positive or not. So if you have a synuclein positive, alpha synuclein positive, your phenoconversion chance to Parkinson becomes more. That way we can interpret. Or on the other hand, as a neurologist, if I am not very sure that a Parkinson, I'm suspecting somebody has Parkinson's disease, I'm not very sure, where we were using trodat and this kind of scans, it will be more scientific to use this biopsy method, because it will prove that we are proving alpha synuclein tissue protein, which is the hallmark of PD pathology.
Correct. It's very interesting. I mean, Dana and I both didn't know about this.
Yes, yes.
Although, oh, this is so very informative. So
Very
one,
important. And most importantly, it won't be very expensive because it's a simple biopsy test.
biopsy. Tell me one thing, doctor. So one thing in Trodat that has helped our members is to accept the fact that they have PD. Like when a doctor says, then they'll go to another doctor till somebody says it's not PD, they'll keep switching doctors. But if a Trodat says Parkinson's then they'll believe, at least to some extent. So in that way, it has helped. But it's also an expensive test. So where in Trodat it is able to say Parkinson's, my question is, in the skin biopsy, if it comes up positive for alpha synuclein, then it could be PD or it could be any of the other three that you were saying. Or will it point out and say definitely PD? I
No.
think it's only positive for alpha synuclein. It could be Lewy body, it could be,
Which is,
might
which
be,
is,
what
which
do you
I
call
would say, sorry to interrupt, which I
it?
would say is much more scientific than looking at the Trodat and saying you have Parkinson. Okay. Because see, Trodat has got a lot of fallacies. Now, I don't think many centers are going for Trodat.
Hmm.
You know? Uh,
See what you're saying, doctor, because if it is alpha synuclein, it is in the family of that disorder.
Yes.
This is,
Earlier, they were doing biopsies from the gut. So it
I,
was more cumbersome because you have to do a colonoscopy and do multiple colonic biopsies. But now, with the simple OPD procedure with the skin, it will be
hmm.
much more easy to diagnose from a biopsy point of view, from a pathological biomarker. I would say this will
Pathological
be a
biomarker.
biomarker.
But it's still not available, illa, doctor.
It's
It's
not
not
yet.
available.
It's just the 2 years. So it will be available in future, I believe.
Hmm. I hope so.
Yeah, then I will be definitely sending them for the
You
biopsy,
have to, doctor.
because that is much more scientific. It will be. I don't
Yeah.
say Todat is scientific. I have no comments for Todat. I'm
Mm.
again reasserting that if it helps the member to accept the diagnosis, there is no harm in that.
Correct. Correct.
Okay, because ultimately we are looking for how the patient members accept the problem
Exactly. So,
and start looking forward, looking for answers for it, and
yeah.
do corrective measures.
Yeah.
Correct.
Yeah.
So if
Correct.
that happens with Todat, there is no harm in that.
Exactly. That's exactly what we tell members. It's not necessary, it's
Huh.
expensive. But if you
But
have the money
but
and you're
at the
having a
same
hard
time,
time accepting the disorder that you have
see,
it, then do it. It's okay.
at the same time, every test has got false negative, false positive. So here we are forgetting those patients, our
Yeah.
members who do not have PD,
Yeah.
who have a false positive product. At
Yeah.
the same time, we are in danger of putting those patients through a mental trauma that you are having Parkinson's,
Yeah. Oh, that's what a
which
trauma.
happens.
Yeah.
My last visit to Chennai 1 month back, I
Mm.
had a very similar patient.
Mm.
He's a famous pub owner. He had multiple restaurants over Chennai. And what I felt all, but he was having a very busy and anxious lifestyle, managing so many restaurants. He was having just some non-specific tremors. I did not feel that he had PD, but
Oh.
he had underwent a TODAT, and he has. So it's not that the having the gun is important. How you should use the gun also is very important.
Yeah, how you just unload it.
My worry is that when Trodat is used by, like, as used rampantly, if any physician is using it and just looking at Trodat is saying that, at that timing, maybe a bit more,
Correct, correct.
a
It
bit,
is so nuanced reading of the,
of
yeah,
course.
that's a
We have to be careful. I have
fair.
nothing against any doctor using it, but we have to be careful interpreting the results before we put into the patient.
Got it, doctor. Good. So I think this was a lot of good information. Just to quickly sum up before we move on, the doctor is saying that if just because you have genetic predisposition doesn't mean you'll, yeah, be affected with Parkinson's. And there are a lot of new studies that have come, like skin biopsy, where it looks for alpha-synuclein, which is indicative of, disorders like Parkinson's. And there is a phase, this prodromal symptom. Is it, doctor? That's what you were saying.
Yes, yes.
That is when you have non-motor symptoms like constipation for like last 10 years,
We do.
restless eye syndrome, then
Yes.
they're all indicators
And
of
sleep
Parkinson's. If
behavior
you've
disorder.
had somebody in your family with the disorder and you're experiencing some non-motor symptom like that, then maybe you can get a test done to see if whenever it's available to see, are you exhibiting signs of Parkinson's? You catch it early, then it is good to manage it early so
Manage
the
it.
disorder doesn't progress as much. That's the idea.
That's
Doctor,
absolutely, absolutely.
Doctor, one
And
another thing.
management doesn't mean medication always.
That is my question. Next segue to that.
So
So
it
a lot of members also hesitate to take dopamine.
correct.
Syndopa. They'll be like, I'll manage now. I'm okay. That's the honeymoon phase of first 3, 4 years. So they're like, I'm almost like normal, just little bit pain here and there or tremors here and there. I don't want to take medicine. What is your
There's nothing harm in that.
don't take medicine?
No, I have patients who are not on medicines.
Oh yeah, is it okay? Because
Yes.
Anna and I are always telling them, please take
Of course,
Syndopa.
very less. Of course, very few of them, because
Yeah.
most of them already they come in a very because I am a referral doctor. I'm an expert, so I get referrals. So, but I let me reiterate this fact. When I was working with my boss, Professor Lim Sheng in Malaysia, we used to have this group of patients, few of them, who used to come for a regular checkups, but they are not on any medicines.
Mm.
So they say that one of them I still remember was a very high profile functioning CEO of a company. He was a Korean, and he was perfectly fine. He was able to do his meetings, he was able to do all his lifestyle. So he was doing a lot of yoga and exercise and all the non pharmacological methods. And he was timing his day like that when he was down, he was taking rest. When he was good, he was working. So he was able to manage. So for a long time, almost for a year or two, I guess, he was off medicine until I was there in the end of the fellowship. He was not started on medicines. So it does not mean that we have to push them for medicine always. I
Oh.
mean, it has to be a collective decision. But at the same time, I would say that if somebody is really struggling on his gait, we have to convince that person member to take the medicine because he will fall and injure himself.
Correct, correct.
So
Tell me one
this
thing, doctor,
is a
though.
decision
If
which I
they
think
don't take Syndopa earlier on, as soon as they're diagnosed, will it not lead to more progression of the disorder
I
faster?
don't think we can say for sure that taking Syndopa early will prevent PD progression.
Okay. Okay.
I don't believe in that,
Hmm.
and I don't think there are any clear-cut guidelines which says that to start Syndopa early, it will prevent PD.
No, no,
What
no,
is
no, 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 not prevent. It'll
progression of PD? Prevent
less
progression of
progression.
PD.
Ah.
That's what. There are two questions in this.
Hmm.
So it will not prevent progression of PD. What studies have shown, like the the clamp PD trial and so many other trials have shown, what it will actually prevent is it will improve the quality of life.
Yeah.
So if you are not taking medicine, and if you are taking medicine,
Hmm.
definitely with medicine, your quality of life, if you have Parkinson and if you are diagnosed correctly, and if you do not have the PD plus variant and you do not have the other kind of, definitely if you are classical garden variety of Parkinson's disease, with medicine, your quality of life will be better. That is what we are talking about. And that is where we should understand that giving medicine early means that we are preventing injury, we are preventing falls, we are giving you a better cognition, because it will elevate your mood. Otherwise, depression, apathy is one of the very significant factors. Many of these patient members get depressed and family is not aware.
No,
So
that makes sense. It's saying the disorder will progress. I mean, not like you're
we
saying
don't know
Syndopa
how
will
it will
progress
progress.
any less. You're
Yeah.
saying it's just it'll help you live your everyday life better.
Yes. Yes.
But if you're able to live your everyday life better, then don't force
Yes.
Syndopa on you.
Yes. Yes. That's what
That's
I
what
want to say.
that's what you are saying. I mean, of course,
Yes.
each doctor might differ in terms
Very,
of
very
what
good.
and combination, but
Some
this
may
is a
argue
good
on this point that,
perspective to
okay,
know.
you should start on selegiline or rasalogine or MAO inhibitors because they have shown some degree of protection.
Uh,
Now if I asked that particular doctor that what is the degree of protection, how much it protects, we are not in the way to answer that question, honestly. But if that belief is correct, there is no harm in giving. That's what is my point.
Fair enough. Fair enough.
What I
Uh,
what, what I want to re-stress is that there is nothing gray and white and black here. There is a gray zone here always, and we have to value everybody's thought process.
No, no, that's fair. So, can you maybe spend some time on these agonists that you talked about right now? It need not be dopamine itself, but medicines like Raselect and others, you're saying that can be given.
Yeah.
Tell the members or viewers now watching and later, how are they acting on the brain differently than Syndopa or directly taking dopamine?
Yeah, I mean, see here. See, the basic problem with Parkinson medication is that uh, the levodopa directly doesn't enter the brain. It doesn't cross the blood-brain barrier. So God has given us mechanism where it is transported and then it is in the dopaminergic neurons. It is made there, through a complex process using phenylalanine, nephrin, tryptophan, and so many enzymes and all that. But what has happened is these dopaministic agonistic drugs, they are kind of enhancing this mechanism rather than directly providing dopamine. They are enhancing this mechanism, but these are the drugs which can be started early in the disease. So there is a thought. There are two school of thoughts here. One school of thought believes that we should start levodopa early. Another school of thought believes that we should be and maintain on dopa agonist for as long as possible. You know, the only difference which has come here is that patients who are, and which is now proven also from some of the more longer studies, is that patients who are on started on dopamine, I mean levodopa early, they are definitely going to get more dyskinesias at some point of time. Okay, but again, having said that, that doesn't mean that dopa agonist itself is very good because they may not be as effective as levodopa. Because whatever said and done, nobody will deny the fact that levodopa is the gold standard of treatment. So I am of old school thought person, and I am more into levodopa rather than dopamine agonist.
Oh, you are?
Yes.
Interesting.
So
It's
I
very interesting. And I'm glad that you mentioned both the different, instead of saying my way is the only right way, you're saying there are two different kinds of thought processes. They believe, some doctors believe, because we have had doctors who say one way or the other.
correct.
I'm glad that, this is interesting.
No,
Doctor,
nothing is wrong in this.
nothing is wrong. It also depends on the doctor. More importantly, how the affected person reacts to the medicine. For
Correct.
some, this will
So,
work, for some
so
won't work.
what I have seen, and we have done some research also in this, that the amount of impulse control disorders or
Mm.
ICD, which is a very, very important side effect of dopamine agonistic drugs. You know, I would like to bring attention of members on this particular symptom. It is impulse control disorder is like basically you are not able to control, like you develop hypersexuality or you start spending a lot, you start buying online shopping too much, or you are addicted to cartoons or games. So these are called as impulse control or behavioral disorders. So this is one of the very prominent problems with dopamine agonist drugs, and these are seen more commonly in younger patients. So, and now when we are talking about, and these are the group of patients where we are talking about delaying levodopa, because we want to, for whatever reason, we want to delay levodopa in these patients. So, if in one of the studies, it was actually the impulse control disorders in our country and in Asian group subcontinent is in fact reported very less. Patients are not aware that this could be an impulse control disorder, and that is why in up to 30 to 40% of them may have it may be a very high degree of impulse control, and that is why I have some aversion towards, that is my way of thought process. I do use pramipexole a lot. Among all the dopa agonistic drugs, I think I am not using Rasalec.
Okay,
Over the last 5 years I have not used.
I see.
Okay, after I came back, the only dopamine agonistic drug which I use is pramipexole, and I kind of see in a very high level up to 3 milligrams. Also, I have gone, but I keep a very good check on my patients about impulse control disorder, and I do sometimes spend and educate them that if, or I tell their spouse that if such a such thing is happening, please let me know, because they may. So that
Yeah,
is the only reason I have some aversion towards the dopamine
yeah,
agonistic
yeah. And
drugs.
also in older members, this leads to hallucinations also.
Hallucination, of course.
Very much.
Hallucination,
Maybe not younger people. From what you're saying, I'm sensing younger persons affected with PD with a high dose of agonists have impulse control issues. Older also have impulse control issues and also high levels of hallucination also.
yeah, doctor. Yeah, madam. Sir. But I am not much worried about hallucination. I am more worried about you spending the patients these ICVs.
No,
Once
no,
you
you're right. No, you're
once
right. It's causing an issue. No, you're spending all the
once you see
money.
an ICB, you are really scared because either
Yeah.
they have lost the money, or there has been a social problem because of hypersexuality,
Mm.
or their addiction has become so much, then it has. So those are dangerous. Hallucination is something family members will recognize. It's very scary.
It's affecting the caregiver much more.
Caregiver a lot, but what happens is that it can be managed.
Yeah. Absolutely. No, that's a fair, practical
To
way of
some
looking at it.
extent, it is not that injurious.
Yeah, it's not like, yeah.
I
Uh, Doctor, let us maybe now spend some time on. We've had some questions from the members, knowing that you're coming.
okay.
I will leave it to Dana to ask one question by the other. Just rank them according to you in the order of importance, Dana, and go ahead. Why don't you ask? Unmute yourself.
Yes, Sudha. So, doctor, first question is, what is the use of Syndopa CR 125?
Okay. So, see, uh, any controlled release medication is to give you a more longer on, okay, whether you use it as a Syndopa CR or whether you use Syncopon where you add a drug etacopon to prolong the levodopa action. My usage for Syndopa CR usually is at bedtime dosing. So, bedtime dosing,
Okay.
dosing at bedtime, so that the patient gets a better sleep quality and better turning in the bed. But
Okay.
again, having said that, it's not a hard and fast rule. There are patients who would get up at 1 o'clock and take medicine. So for them, even the Syndopa Plus will work well. Okay, but CR definitely is I use a lot in my practice, and what I feel it's a very good drug to give a more longer, especially in bedtime.
Okay.
I just, Tana, one second, I just want to a little bit explain what doctor is saying. So CR, Syndopa CR, the CR stands for controlled release. Means the drug is getting slowly released, not quickly at one shot. So the impact of the medicine stays longer. So if you take it in the night, it is slowly released throughout the night. So when you wake up in the morning, you're not waking up with a dopamine major deficiency and unable to get up from the bed, unable to walk. All that will be avoided, and you'll maintain a level of dopamine. So
Yeah.
there won't be a crash in the morning. I think that's why doctor is saying night
And,
times.
a lot of studies, sleep quality improves.
Exactly. A lot of members have said this also, doctor. They're
Sleep,
sleeping better after Syndopa CR. You need the dopamine even to sleep,
yes,
actually. Yes.
yes, yes.
Go on, Tana. Go on.
Okay. So, doctor, but in daytime they are taking Syndopa CR, doctor. So why is it
Yeah,
given in between Syndopa?
yeah. So some of my patients I do use on daytime also. Where why I do that is that because I do not want to give them individual immediate release Syndopa plus dosing on a higher dose. You
Mhm.
know, because what it will cause is it will cause more of dyskinesias in these patients, or some of them may feel very sleepy. It may act in another way also with Syndopa plus. So, or even with pramipexole or dopamine agonistic drugs. So, to give a baseline, Syndopa dosing in the daytime, I sometimes add Syndopa CR in the daytime, but usual practice is at the bedtime.
Okay. Okay.
There's
Thank you.
nothing wrong in that. Yeah.
Okay. Next question is, will DPS be effective in case of an patient is suffering from dystonia?
Yes,
What will their life be like after surgery?
okay. So, see, DBS with dystonia, uh, I don't know whether the patient is asking Parkinson with dystonia or
Yes.
primary dystonia. That is
No,
not
no, sir. Parkinson's with the dystonia.
Parkinson with dystonia. So that's a very good question. DBS is definitely effective for off-period dystonias. In fact, I have a couple of patients whom I have done DBS. Only reason was that they have significant amount of foot dystonia because they were during off period the foot has significant amount of for the other members who don't know what is dystonia is simple way it's basically that the particular limb or the foot or the neck get twisted in an abnormal posture, you know, and that is because of it's also a part of it's a separate movement disorder. But in Parkinson's disease, it can come either when your medicine is acting, that is called as on dystonia, or it can come when you do not have the dopamine or when you are in off phase. So I think most of our members know what is on period and off period. So it may come in the on period dystonia, it may come as an off period dystonia. So if the patient is having significant amount of off period dystonia, those are the cases definitely they will respond and it should respond to levodopa. That means that dystonia improves when you take the levodopa. Definitely that patient will be better off with DBS. So that's the question, answer to your question.
Doctor, just to clarify, it also helps on time and off time dystonia. It helps
Mainly for off time dystonias.
off time. Oh, that's
Okay.
good. No, that's good then.
Off time dystonia. On time dystonias are difficult to manage actually, you know. So it is a bit difficult to manage, and when a patient has a very significant on time dystonia, I'm little discouraged to put them in DBS. But again, if the on time dystonia is coming because of a high peak dose of medicine, again DBS it may help to those patients because your medication is going to come down if you are doing STN DBS, not with GPI maybe.
Yeah, it's very interesting
Yeah.
about on time, off time dystonia. Maybe this member you'll have to ask them எப்ப வருது dystonia
Yes. Yes.
after taking medicine or in between both doses of
Timing
medicine.
முக்கியம்.
Time.
Timing.
Okay.
Dystonia.
Dystonia எப்போ dystonia இல்லையா அதான்.
Dystonia என்ன ரிலேஷன் மெடிசின் கூட என்ன ரிலேஷன் இருக்கு அதுதான் ஃபர்ஸ்ட் பார்க்கணும்.
So
Okay.
important. This we'll also keep in mind. We didn't know about it can't be treated during, I mean, it's difficult to treat during on-time dystonia. And even what is the reason for on-time dystonia as well? If
No.
it is excess medication,
Yeah, or
then
it's off state. So it's a symptom of an off state. Like some of the patients, they may not have limb dystonia. I remember one of my patients who has significant abdominal dystonia. So the muscles in the stomach, no, the anterior stomach muscles, they will get stiff. And before he came to me, he went into several gastroenterologists, thinking it is a gastric problem, and undergone several times endoscopies, colonoscopies, nothing was found. Then when he came to me, and then I thought, and I was also not sure initially because I have not seen such a significant abdominal muscle dystonia. But then I found out that I felt it was a dystonia. And when I arranged the medication and when I timed and did the PD charting and all that, now it's been almost like I am seeing that patient for more than 4 or 5 years now, I think 3, 4 years minimum. And he's much better.
how did you diagnose the stomach dystonia itself,
I
doctor?
don't know how I diagnosed. I had I had a hunch, that
Yeah, because you're looking at the whole
looking at the
stomach.
whole thing that maybe the muscles are getting stiff. And he used to come and say only, I am only fine. And a muscle will become like a board, like rigid, stiff. So I used to think it is just an off-period rigidity. But then he will get crampy feeling. He will have other symptoms. That's why he was diagnosed as IBS also, irritable bowel syndrome, multiple time colonoscopy, because that was only prominent symptom in him. So, but then with medication adjustment, he became very good.
Oh, that's interesting. I think some of our members do complain of this. I'll keep this in mind.
Yes, yes, yes.
Okay, okay.
It's very interesting.
Yeah, yeah.
So
Because
next question, doctor, most
stomach
common
is the
question.
first thing we will think always it is a GI problem. Correct? No. Gastric irko, illana medicine now the gastric irko. We will think like that only, no?
Yeah, yeah. A lot of them complain about stomach
Stomach.
tightness, gas,
That is
always
of
pain in stomach.
Stomach ulcers.
ulcer kadiyadamma. It's about the
Body
muscle.
and tight.
Right, right.
Tight. So that is a off-face symptom actually.
Interesting.
Okay. So, Doctor, Ada, next question is most common one, cost of DPS, doctor.
That is something I would say that, see, cost has in the last 4 years have definitely gone up. Okay. The reason for that is the technology is improving. And after a lot of external factors like the war and all that, so the cost has gone up. But in a decent center, I would say definitely, madam, can I speak in this forum about the cost? Okay. So with her permission, it will be roughly somewhere between 22 to 25 lakhs is the usual. If you are going for a rechargeable battery. So just to let you, the fact is till now in Chennai, I have never done a non-rechargeable. I will not do any non-rechargeable. I am not interested in doing non-rechargeable because I do not want patient to go through another unnecessary.
Another surgery to put another battery in, which is again as
I
expensive.
tell them, you please wait. It is not an emergency surgery.
Yeah.
Arrange money for a rechargeable.
Yeah.
Go for a rechargeable because that guarantees you 10 to 15 years of battery life.
Yeah, again, why do it? No, yeah. Same cost, then you're just splitting it in some time.
It's my personal thought. I am not against doctors who are doing this thing, but everybody has their own way of practicing. I personally believe in non-rechargeable battery, and one of the companies which is the leading companies, they are doing quite good job. They have a good, very technical support also. But this is not the forum to name any company. All companies are good. But what I would say is that my preference will be rechargeable.
Yeah. In fact, doctor, I'm thinking we'll have a separate session on DBS itself. But
Yes.
quickly now, since Dana has brought in a couple of questions on cost and dystonia with DBS,
Correct.
so why don't we just spend a little bit
Yeah,
time?
because today already we have a long session. So
Yeah, it's almost time. So, but just tell me, just quickly, who cannot get DBS done?
okay. So in a simple golden statement, I will tell. If you are a patient in whom you feel levodopa is not working, please do not do DBS.
You're
So
taking Syndopa, it's not working, so
yes,
don't do DBS.
don't do DBS because the golden rule is you will get the benefit only whatever you are getting from the levodopa. We are trying to smoothen out your effect, trying to lessen out your medicines, and give you a more sustained on period. So from the beginning, if our start itself is complicated, that your medicine itself is not working, I don't think you should go for DPS.
Okay.
This is a general rule, but if you ask me a technical question, the technical answer is PD plus. If you are suspecting another illness or patient has significant swallowing, gait, balance, all that. So those are individual points in the UPDRS. But in general, if the medicine is not working well enough, I think we have to really doubt the candidacy for DPS.
Okay. And what is the biggest changes you have seen in your patients who have undergone DBS? The quality of life, how has it increased? Just one or two, briefly.
That's a huge question.
Huge, yeah, it's just one or two.
Question, and I would say, for every patient of mine, see, one thing people have to realize that you cannot be completely normal after DBS. You can never be. That's the truth. Okay, but in the 1 year or 2 years, 3 years down the line, when I ask them this question, and I do ask them this question, do you think DBS has helped you? So they say yes. What is the biggest change is that maybe the medication usage. And second thing, better on time. So in spite of even if the medications have not come down, they feel that the on is better, which was not there even with medicine. And that's why we have done DBS. It was there, but it was very short. So it has to be there. If you do not have an on with levodopa, you are not a candidate for DBS.
Correct.
But the problem happens is as the disease progresses, your on becomes shorter and shorter. So that is where the DBS chips in, or any kind of other kind of surgeries chips in. Okay, I think we should have a surgical session separate.
Yeah, we should just have a DBS because you're a DBS specialist in more ways than one.
I'm a PD specialist to correct.
Yes, but PD is also quite a bit, doctor. Not all neurologists, not all doing PD do DBS as well as you do.
Special interest in DBS.
Yeah, exactly. Dana, do you have any questions?
So the one question I have to ask. So one of our member has psychological issues. So she's taking for more than 5 years medicines. So she can eligible to DPS, doctor.
So this is a very important question. We have to see what exactly is that psychological question.
Anxiety, doctor. Anxiety. For anxiety, she is taking medicine for.
Anxiety is not a contraindication for DPS. Okay. So the anxiety can be a off symptom also. So many of them even can become very restless when they are off. So if that is the question, if that is the status, it's not that it disqualifies her from DBS. What is important is that has she developed any psychosis or any significant cognitive problem? So in this kind of patients, we have to do a good detailed neuropsychological evaluation by a psychologist, have a detailed report, and then based on that report only we have to decide and look into whether the patient has hallucination or memory problems, cognitive problems, behavioral issue. When all that is there, then only we have to decide and see what we can do. So I don't think that itself alone is a problem.
Yeah, fair enough, doctor. And I think we have taken enough of your time in this 1 hour.
Yeah.
Dana, if you don't have any further questions.
No questions.
We'll always join again if the members are interested.
Yeah, so because PD itself is very vast in its
Right.
scope and from understanding it to managing with medicines, because we've had separate sessions just for medicine, separate for DBS, separately for psychosis issues. So we've had individual couple of hour sections for each of them. So we can't compress obviously all of it into one, but today was a definitely very interesting conversation, doctor. We dwelled upon a lot of things in the initial phases of PD. And a lot of misconceptions also. So very helpful. Cannot thank you enough as usual for the time you give us and for the attention you give all our members. And this is not the last, this is the beginning of, we have been working together. So such sessions, more such interactions.
Thank you.
More power to you.
Will you
Thank you
be,
so much.
okay. Will you be
Thank
giving
you.
a YouTube link or something? You have recorded this?
Yes, yes, doctor. Why don't you just stay 1 minute? Dana, do you have anything to say
No,
before I
thank you,
just
doctor. Thank you so much for joining us. Thank you. Thank you.
Thank you. Thank you, everybody.
1 second?